In this lesson, I will discuss about acquired aplastic anemia. As you know, aplastic anemia is a pancytopenia. Pancytopenia is a condition in which there is a lower than normal number of red and white blood cells and the platelets in the blood. Pancytopenia occurs when there is problem with the blood-forming stem cells in the bone marrow. When we see the etiology of aplastic anemia can be caused by some problem or secondary, or it can be idiopathic. When we say secondary, it can be caused by drugs, chemicals, toxins, infectious agents, radiation, and immune disorders that can result in pancytopenia by either direct destruction of hematopoietic progenitors or disruption of the marrow microenvironment or immune-mediated suppression of marrow elements. And many cases of acquired marrow failure in childhood are idiopathic. That means no causative agent is identified. Many are probably immune-mediated from those idiopathic ones. So activated T lymphocytes and the cytokine destruction of marrow stem and the progenitor cells can occur. Patients with an initial diagnosis of acquired aplastic anemia may have developed somatic mutations in genes associated with myelodysplastic syndromes and acute myeloid leukemia. Severe bone marrow suppression can develop after exposure to many different drugs and chemicals, including certain chemotherapeutic agents, insecticides, antibiotics, anticonvulsants, non-steroidal anti-inflammatory drugs, and recreational drugs. Some of the most notable agents are benzene, chloramphenicol, gold, and 3,4-MDMA. A number of viruses can either directly or indirectly result in bone marrow failure. Parvovirus B90 is classically associated with isolated red blood cell aplasia, but in patients with sickle disease or immunodeficiency, this virus can result in transient pancytopenia. Prolonged pancytopenia can occur after infection with many of the hepatitis virus, herpes virus, Epstein-Barr virus, cytomegalovirus, and the retroviral. Patients with evidence of bone marrow failure should also be evaluated for inherited forms of marrow failure, paroxysmal nocturnal hemoglobinuria, and collagen vascular disease. Pancytopenia without peripheral blasts might be caused by bone marrow replacement by leukemic blast or neuroblastoma cells, or secondary infiltrations of bone marrow from distant problems. Regarding pathology and pathogenesis, the hallmark of aplastic anemia is peripheral pancytopenia coupled with hypoplastic or aplastic bone marrow. As you know, myelodysplastic syndrome is a pancytopenia as that of aplastic anemia, but the bone marrow is hypercellular. But in the case of aplastic anemia, the bone marrow is either aplastic or hypoplastic. The severity of the clinical course is related to the degree of myelosuppression, and we say severe aplastic anemia if the following two conditions are fulfilled. That means if absolute neutrophil count is less than 500 or platelet count is less than 20,000 and retic count is less than 1% after correction for hematocrit, and the bone marrow biopsy material has less than 30% cellularity or hypercellular bone marrow. Approximately 65% of patients who first present with moderate or non-severe form of aplastic anemia eventually progress to meet the criteria for severe disease if they are simply observed without treatment. Pancytopenia results in increased risk of cardiac failure, infection, bleeding, and fatigue because the three cell lines are decreased or absent. Acquired pancytopenia is typically characterized by anemia, leukopenia, thrombocytopenia, and the setting of elevated serum cytokine values. Careful examination of peripheral blood smear for RBC, leukocyte, and the platelet morphological feature is important. A reticulocyte count should be performed to assess erythropoietic activity. To assess for possible paroxysmal nocturnal hemoglobinuria, flow cytometric analysis for erythrocytes for CD55 and CD59 is the most sensitive test. Bone marrow examination should include both aspiration and biopsy, and the marrow should be carefully evaluated for morphologic features, cellularity, and the cytogenetic abnormalities. When we came to treatment of aplastic anemia, the treatment of children with aplastic anemia requires comprehensive supportive care coupled with attempt to treat the underlying marrow failure. For patients with human leukocyte antigen matched family member donor, allogenic hematopoietic stem cell transplant offers 90% chance of long-term survival. For patients without a sibling donor, the major form of therapy is immunosuppression with different immunosuppressants such as methylprednisolone, cyclosporine with a response rate of 70 to 80%, and the median time to response is 6 months. As many as 30% of patients responders experience relapse after discontinuation of immunosuppression, and some patients must continue cyclosporine for several years to maintain hematologic response. Among those who relapse after immunosuppression, approximately 50% show response to second course of treatment. Regarding complications, as we expect, the major complications of severe thrombocytopenia are predominantly related to the risk of life-threatening bleeding from severe thrombocytopenia and infection secondary to protracted neutropenia. Patients who have been transfused with RBC regularly over a long period are at increased risk of developing alloantibodies to RBC antigen, and they may require iron chelation therapy for transfusional iron overload. Regarding prognosis, spontaneous recovery from pancytopenia rarely occurs, and if left untreated, severe pancytopenia has an overall mortality rate of approximately 50% within 6 months of diagnosis and of more than 70% overall. Infection and hemorrhage being the major cause of morbidity and mortality. The majority of children with acquired severe aplastic anemia show response to allogenic marrow transplantation or immunosuppression, leaving them with normal or near normal red cell count. This is all about a summary of acquired aplastic anemia. Thank you for watching.